Hi everyone, Steve Shin here from Los Angeles, California. I apologize for not being there in person to give you this presentation. I really want to go to Milan for this meeting. Unfortunately, I had other traveling to do and had committed to speaking at some other meetings. So hope to join all of you next year, wherever that may be. But thank you, Gordon, for allowing me to present to you in a virtual format. And it's my pleasure to talk about internal bracing in the hand and wrist and return to play. So I'll present a few cases here. I think that this is a fun way to discuss internal bracing in the hand and wrist and what I'm doing for my athletes. So here's the first case. This is a 26-year-old right-hand dominant NFL cornerback with recurrent right thumb pain. As you can see in the fluoro shot here, that he has a recurrent fracture at the thumb metacarpal base. This is a commonly called a Bennett fracture. He had ORIF of it about 2 months ago with these two small screws, and he obviously broke through it again. He's got pain, swelling, and some crepitus at the base of the right thumb. I recommended revision fixation, pretty obvious. So I went ahead and removed those two little screws and was able to get the tips of these three screws into that Bennett fragment and got a pretty decent reduction. And this was pretty solid. I was pretty happy with this fixation. And I thought that would be it. I'd be done, and he could start moving within a couple of weeks. But I got a fluoro video and saw that the thumb metacarpal base was actually not very stable in the joint. You can see that's very obvious subluxation of the thumb metacarpal out of the CMC joint, and this is really contrary to dogma. What we learn is that that Bennett fragment is stable in the right anatomic position, and as long as you fix the rest of the metacarpal to that piece, you shouldn't have any more instability at that joint. However, that was obviously wrong. So this slide just shows some of the basic anatomy of the thumb CMC joint and the ligaments there. The mechanisms of injury of a thumb CMC joint injury is an axial force on a flexed thumb. Sometimes you'll get a pure dislocation, which is rarer. More often you'll get a fracture dislocation of the thumb CMC joint, such as a Bennett injury. And what people have found over the years is that the dorsal-radial ligament here circled in green is much stronger than the anterior oblique ligament, which is also called the beak ligament. This is actually a very advantageous thing for hand surgeons, as we are able to access the dorsal-radial ligament much easier than the beak ligament. With this knowledge, I want to go into the lab and do a biomechanical study to see if internal brace augmentation improved the strength at time zero of a repaired dorsal-radial ligament versus a repaired dorsal-radial ligament alone. I know this type of study has been done for other ligaments throughout the body, but I specifically want to see how the IB augmentation would work for this ligament. And we did indeed find that IB augmentation improved the load to failure characteristics of DRL repair without compromising range of motion, which is really nice to see. On the left here, you can see an intraoperative photo demonstrating the screw fixation of the metacarpal base fracture, as well as the holes in the dorsal metacarpal base and the trapezium, where I placed the swivel lock anchors for the internal brace. And you can see in this video here how stable the CMC joint is now after that dorsal-radial ligament was repaired and augmented with an internal brace. Postoperatively, he wore a thumb spica splint for the first couple of weeks, but with the IP joint free to allow motion there. At about week 3, I let him start active range of motion exercises for the thumb CMC and MCP joints, and then he was finally able to return to play with the splint, as pictured here, about 3 weeks after surgery. It's usually about 3 to 4 weeks when the pain is tolerable that the player can go back with the splint in place. But if they can't go back to their sport with the splint, then I'll have them go back around 8 to 10 weeks postoperatively. The next case is a 38-year-old right-hand dominant NFL quarterback with a right thumb injury. The MRI on the left here shows an obvious complete ulnar collateral ligament tear at the thumb MCP joint. You can see that it's torn distally off the phalanx, which is the usual case for these injuries. Much less common are the proximal UCL or mid-substance tears. He had a complete tear of the UCL and instability on exam, lack of firm endpoint in both the full extension and 30 degrees of flexion at the thumb MCP joint. On the right here, you can see that I'm holding the distal end of the ligament with my as and forceps. You see some shredding of the accessory ligament below. I could have made it for a more dramatic picture by flipping the ligament backwards, but I forgot to do that. In regards to traditional surgery, this would consist of a simple suture anchor repair, just one anchor in the volar ulnar base of the proximal phalanx. Then we'd cast the thumb for about 4 to 6 weeks, and then start therapy. Obviously, they're getting very stiff and atrophied during this time. Return to play would be about 6 to 8 weeks with the splint, if they're able to play with a splint, but sometimes longer. And if I'm not able to play with a splint, I would keep my patients out for 10 to 12 weeks. I'm too afraid of the ligament getting re-injured if they went back any sooner than that. Here's just a picture of a UCL repair with an internal brace or suture tape augmentation. I actually use smaller anchors now that are metal. I don't use these 3.5 millimeter peak swivel lock anchors anymore, but I do have 2 strands of the suture tape spanning the ligament as the internal brace. Here I'm showing the repaired ulnar collateral ligament, and you can also see the 2 strands of the 1.3 millimeter suture tape spanning the ligament from distal to proximal. The key step in this surgery is to secure the augmentation, secure the second anchor in the metacarpal with the MCP joint flexed about 30 degrees and neutral in the coronal plane. We know that the proper portion of the UCL is most taut in 30 degrees of flexion, so that's why we want to secure the augmentation in that degree of flexion. If you do it in full extension, the patient will lose flexion at that joint. So this is a key step of the surgery. Here are a couple of floor shots now of what I do now for this surgery. Again, like I mentioned before, instead of using those peak anchors, I like to use these smaller 2.5 millimeter nano swivel locks. And you can see them. One advantage, obviously, is that you can see them under fluoroscopy or radiography. And these allow for much smaller holes in the bones, only about 2 millimeters in width. Obviously, you want to make sure that the patient has a good range of motion prior to closure. So that's what I'm demonstrating here. I want to make sure the thumb has good flexion and opposition. I want to make sure they have good extension. And also, you want to make sure there's a nice firm endpoint, which there is, with radial stress at the joint. Just make sure there's good motion here before I close it up. And before actually I even cut the suture tape tails. If I don't like it for whatever reason, if I think it's too tight or too loose, I can always take out the swivel lock in the metacarpal and retension it and just do it again. So here is that same quarterback at post update number 2. You can see that he's beyond with the therapist already here. He is now doing his active exercises to try to improve motion at the joint. This is only post update 2. There's no way I would allow a player to do this post update 2 with just a traditional repair and just one little knot repairing the ligament back to the bone. So with the peace of mind afforded by the internal brace, I let them start motion very early, usually about post update 2 or 3. This player was able to return to throwing about 4 weeks post-operatively and to a game about 6 weeks post-operatively. We did a couple of biomechanical studies as well. And the first study that we did was looking at a repair alone to a repair of the UCL with internal brace augmentation. That's a study up above. You can see on the right here that the internally braced ulnar collateral ligament was 4 to 5 times stronger than a repair alone. We also did a kinematic study with Ty Lee here in Southern California of the thumb UCL with suture tape augmentation, and found that the kinematics were very similar to a repaired UCL or an intact UCL, and that the thumb UCL repair with internal brace demonstrates higher angular stiffness and restored varus valgus kinematics at the thumb MCP joint. We also did a clinical study looking at return to play in athletes that had thumb UCL repair with suture tape augmentation. At the time of the study, we had looked at 13 athletes that had in-season surgery and found that a return to play at any level was about 31 days. And by any level, I mean even like a rehab assignment for a Major League Baseball player. But return to play at the same level was just over 5 weeks, about 36 days. Obviously, there's some error there as well, but still, overall, about half as it took we cut the time for return to play, traditional return to play, in about half. So if traditional return to play was about 3 months, right now we're at about a little over 5 weeks. That's pretty good. Next, we're going to look at a 26-year-old right-hand dominant NFL wide receiver with a recurrent left small finger injury. This player had a left small finger PIP joint RCL repair about 4 years ago when he was with another team, and it obviously failed, as you can see here in the picture. He recurrent instability and pain. On exam, the joint was actually reducible, but he still had some mild deformity due to some arthritis that was present already at the ulnar aspect of the PIP joint. Unfortunately, I don't have an X-ray to show you this today. So we talked about all the different options for him. We talked about a revision repair, which was actually not initially my first choice. I thought it would fail very quickly, and he would eventually need a fusion done. That was actually my preference. But we also discussed reconstruction with a tendon graft, amputation, which he didn't want, and he obviously didn't want to live with it since he was presenting to me and in a lot of pain. So after a lot of discussion, we decided to try a revision repair. So on this slide, you can see kind of from left to right. First on the left, you can see that kind of bouquet of sutures and suture tape coming out of the hole at the radial aspect of the head of the proximal phalanx. In the middle, you can see that I've repaired what was left of the ligament there. And you can see the suture knots there, and you can see the tape coming out of that hole. And then finally on the right, a little hard to see, but I've actually brought the tape distally to the base of the middle phalanx and secured the tapes there with another nano swivel lock anchor. So there are a total of 2 nano swivel lock anchors for this internal brace augmented RCL revision repair. So here you can see the closure on the left, and then on the right you can see the 2 nano swivel locks in place. You can also see the bit of arthritis there at the ulnar aspect of the PIP joint. He did not have any pain with passive motion at that joint, with the joint reduced preoperatively. So I was encouraged by this, although I did tell him that football is a tough sport and it's very likely that this will fail quickly and that you'll eventually need a fusion. So here he is 2 months post-operatively. You can see that finger looks pretty good. You can have full range of motion, and extension and flexion at that joint, and you can see here in the video that he actually has a nice firm endpoint with the ulnar stress at the PIP joint. So I'm pretty encouraged by this, only 2 months out, but again, football is a tough sport, and I wasn't surprised at all if this revision repair, even with the internal brace, would fail. So he was actually able to play one season most of it without pain, and was quite happy with it, catching balls and doing what he needs to do. But after that season, he came to me and said at the end of the season he started having some pain at the joint, and was having a lot of difficulty doing what he needed to do with the football. And so if you look at it here, it doesn't look too bad. Maybe some mild apex radial angulation at the small finger, but really not too bad. If this was anybody else, not a football player, I probably would just leave this alone. and let him have his motion at the joint. But because of the pain, he said, "Okay, I get it. Let's go ahead and do the fusion." So now I had to do another surgery, his third surgery on this joint to fuse the joint. But that was I believe the right thing to do for him now. So here's just a slide showing the tension band fusion construct I performed for his left small finger PIP joint. He fused well and is currently playing without any problems. Next case is a 23-year-old right-hand dominant Major League Baseball outfielder that was diving for a catch. He presented with pain and swelling and limited motion at his right wrist, and I apologize for the poor quality coronal cut of the MRI here, but as you can see, he has this gapping between the scaphoid and lunate bones, an obvious complete scapholunate ligament tear, and so this is a tough injury for any athlete, and we discussed the different treatment options. So we had a good discussion of this difficult injury, and I told him that, listen, there's no treatment that works all the time. You can see from the slide here several of the techniques that have been described by very famous surgeons over the years to try to keep these two bones together and reduced, but I personally have not found the holy grail technique for this difficult injury. Since internal bracing was introduced, several different authors have been trying to utilize this concept for this very difficult injury, as you can see here, just from what's been published. And I think we're still looking for that answer, but I do think internal bracing is a big step in the right direction for treating this very difficult injury. So this is what I'm doing now. I call this the SLZ reconstruction because it kind of looks like a Z right there. So it stands for scapholunate Z reconstruction. It has the unfortunate nickname of the sleazy reconstruction. I got to think of a better name and get it out there quick before that actually catches on. This reconstruction utilizes four 2.5 millimeter nano swivel locks, so these smaller ones that I like. They require just smaller 2 millimeter or 2.2 millimeter holes. And I can get 2 suture tapes into each hole, and even a couple of fiber wire sutures that you see here coming out of the dorsal holes, with which I will grab the dorsal capsule and perform a capsulodesis. This is an intraoperative photo of the patient's scapholunate ligament tear, and you can see that the obvious gapping there between the scaphoid and lunate bones. And you can also see that actually this ligament tear might have been an acute on chronic injury. You don't see the nice kind of thick ligament that's usually still left after an acute injury. So on this slide, we can see an intraoperative picture here on the left demonstrating the SLZ technique. The Z is actually kind of inverse in this right wrist. The suture tapes are one is black and one is blue and white. You can also see the fiber wire sutures coming out of the dorsal holes in the scaphoid and lunate, with which I'll grab the dorsal capsule and perform the capsulodesis. Was able to get some x-rays 2 months post-operatively, and you can see here again the anchor is still in good position, and that the gap is pretty nicely closed up. You can also see that the scapholunate angle on the lateral view here on the right is also within normal limits. So I was very pleased with these x-rays at 2 months. Obviously, this is only 2 months out, and I'm waiting to get longer-term x-rays, hopefully later. But however, the player was able to return to play at 4 months post-op, and left-right wrist flexion extension was about 60 and 75 degrees, respectively, compared to his unaffected side, where it was 85 and 85. And my final case is a 25-year-old right-hand dominant NFL running back who had a fall on an outstretched hand injury, or foosh injury. You can see on these x-rays, and I apologize for the quality of the x-rays, especially on the lateral on the right here, but you can see that there's an obvious lunate dislocation here, and you can see the axes of the lunate and capitate on this lateral view as being off. They should be collinear. Here is an MRI of the patient's wrists, both the coronal and sagittal cusps, and you can see the obvious lunate dislocation here. So the questions that I was trying to answer for myself and for him were the following: do we do this closed or open? Do we repair the ligaments or not? What type of hardware or fixation are we going to use to try to keep these little bones in place? And when are we going to allow him to go back to play with the cast and eventually without? These are questions that are actually controversial, and there's really no consensus on these questions in the literature. And looking at the literature, I was pleased to see this paper come out by Dr. Il-jung Park. He's a senior author and colleagues in Korea, where they entitled Scapholunate and Lunotricutal Interosseous Ligament Augmentation with Internal Bracing and Perilunate Dislocation Case Reports. And they found that IB augmentation can reduce the period of K-wire fixation and cast mobilization and can enable early joint motion. So I like this. I don't like using K-wires, especially in football players, even if they could play with a cast in place. I'm afraid of K-wires breaking or backing out and causing infections. So anytime I can avoid K-wires, I will do that. So for this player, I decided to use all suture anchors instead of the swivel lock anchors I mentioned earlier. I was able to use these larger kind of all suture anchors or fiber tack anchors that I believe are used in the shoulder. I was able to make these tiny holes in the carpal bones here and place 4 of these fiber tack anchors into each of the bones of the proximal row, kind of tie them to each other to get the stability that I wanted within the proximal row. I also used the sutures, the tapes through the dorsal capsule to perform a capsulodesis. After this repair, I let him start moving at 3 weeks. I believe starting range of motion earlier for these athletes is better. Actually, for anybody is better. Traditionally, I would mobilize them for about 6 weeks, but then they get so stiff. So I started starting earlier and earlier with range of motion postoperatively, and I think 3 weeks is about a good time where pain is under control, and they can start moving that wrist without allowing too much scar tissue to settle in. This player was able to start practices at about 4 weeks postoperatively with a 3D printed playing orthosis. As you can see here, obviously this is not his hand. This is a large orthosis on the wrist of one of the trainers, and he's able to return to a game at 5 weeks with this in place just to protect his wrist. Here's an MRI that they were kind enough to get for me of his wrist 4 months postoperatively. This is actually right after the Super Bowl, which he played in. And you can see the tiny little holes here from the all suture fiber tack anchors, which I really like to see. I did see some rare cases of osteolysis within these bones with the larger 3.5 millimeter swivel lock peak anchors. So I think using all suture anchors with smaller holes may be the answer. You can see here that there was some DC of the lunate, but not too bad. So I was pleased to see this MRI 4 months post-surgery. So in conclusion, I think for the smaller bones in the hand and wrist, I think we need smaller implants. We should use smaller implants. The nano swivel locks are only 2.5 millimeters, are great. They're very strong. And I like the all suture anchors as well, the fiber tacks, and hopefully we can make even smaller ones for the hand and wrist. Internal bracing has definitely changed the game for my athletes with hand and wrist injuries. They are allowed to start rehabbing much faster, range of motion and strengthening without worrying about the ligament repair. And so I've seen a lot of athletes return to play much sooner as a result of internal bracing. And I'm really excited for what the future is going to bring with our technologies advancing as quickly as they are. I think the concept of internal bracing, will get even better as we move into the future. So thank you very much for listening to me, and I apologize again for not being able to be there in person. But I hope you got a taste of what we're doing in terms of internal bracing in the hand and wrist. It's really exciting stuff. And I do like to say that, even though I treat elite athletes, I am certainly not one. And I lost a bet, so I have to show this video, unfortunately, in every presentation I give for about a year. So a so-called friend of mine took this video. You can see the pin up here. There's a yellow flag in the upper right, and this is me trying to tee off on a par 3, and the ball obviously doesn't go to the right. It goes to the left. I'm wondering where the ball went. I think the sun was in my eyes. Actually, no, it was right behind me. So anyway,
I took
didn't want to show
lots
this
of good video of that.
But I'm a man of my word. So anyway, there you go. Thank you very much, everybody. Hope to see you at next year's meeting, and I hope you have a great time in Milan. Take care.